Effective discharge planning can decrease the chances that the patient is readmitted to the hospital and can also ensure medications are prescribed and given correctly, and that appropriate necessary home care services are in place. Who will handle meal preparation, transportation, and routine chores? If you must hire someone to perform these activities, who can help you identify resources? Who pays for the services? Medicare states that discharge planning is a, quote, process used to decide what a patient needs for a smooth move from one level of care to another. Not all hospitals are successful in this. Although the American Medical Association and the Joint Commission on the Accreditation of Healthcare Organizations offer recommendations for discharge planning, there is no universally utilized system in U.S. hospitals. Additionally, patients are released from hospitals quicker and sicker than in the past, making it even more critical to arrange for good care after release. Only a doctor can authorize a patient's release from the hospital, but the actual process of discharge planning can be completed by a social worker, nurse, case manager, or other person. Ideally, and especially for the most complicated medical conditions, discharge planning is done with a team approach. We're going to do our best to address the issues I've raised with a team approach. Monica Micklos is a clinical social worker and director of care management for Seabury Resources for the Aging in Washington, D.C. Seabury provides private care management services. Seabury has also been able to help with many of the requests we've received at the Senior Living Foundation for care. Irene Paplos, right here, is the Director of Clinical Health Services for Federal Employees Health Benefit Plans at Aetna. I'd like to ask Irene to talk about care management services offered by Aetna, especially what happens before someone is hospitalized. And then I'm hoping that Monica will describe situations where the services of a private care manager made a critical difference.
Hi everyone, could everyone hear me? Okay, good. So I'm going to talk a little bit about our In-Touch Care program and how our care managers can help you. Once we're notified from the doctors or the facilities that someone is going to have a procedure or surgery, we start the discharge planning right away. So what that means is we have a nurse that will call before you have the procedure, and pretty much she or he will call and pretty much ask you what are your needs, get an idea of where you are and what your needs will be during the hospital and after the hospitalization. So what does that mean? A lot of times we ask, do you have someone to help you at home? Is there someone there that can support you, help you at home, take care of you? Do we need to set up home health care? Do we have to order any equipment? Will you need a walker? Will you need a cane? Those types of things. And then once you're in the hospital, the care manager will call you 2-3 days after the hospitalization, ask how things are going, and then they'll usually call you once you get home. And it usually does not end there. We usually try to deal with, we deal with the acute issue, which means if you had surgery, we want to make sure that everything's okay, you have your follow-up appointments. But then we also, with our program, we deal with the chronic illnesses, which means if you have diabetes, if you have high cholesterol, whatever the situation may be, we also provide education on that and work on that with you. And the nice part with that is you will work with the same nurse. So if something happens in the meantime, you always have her contact information. But definitely we work with the discharge planning. As soon as we're notified of your admission, as soon as we know of the procedure, that's when we start planning and start helping you. And then we also have social workers that we work with, dietitians. So we try to combine all of the entities to help once we're notified of that admission and start the discharge planning.
Monica, I was going to ask you to talk about perhaps a more complicated medical situation where a care manager played an important role. And Monica, the Seabury care managers this is a private organization, and we have to differentiate between care management that is provided, in Irene's case, through the health insurance, and then Monica coming from a private agency, which would be a private pay situation. But anyway, thank you.
So, oftentimes when a care manager gets involved, from a private group or from Seabury, it's when maybe it's the unexpected or when things suddenly feel overwhelming. We tend to get a call, perhaps it's when someone's gone into the hospital, maybe following a fall or an event, and they are looking at the fact that maybe it's either their parent or their spouse are ready for discharge, and it's like, wait a minute, I don't know what I need. And it's wonderful when you can have someone like Irene working with you in advance. That's ideal. There are a lot of times in situations where, though, that people may not have had an opportunity to do much planning. And so there is a panic of, the hospital is saying, I'm ready for discharge, or mom's ready for discharge, and I'm really worried about what's going to happen. And so our care manager will go in, and then we go on site. So we come out to the hospital and we meet and really get to know the situation. And one of the first things I would say that's so important is just communication. So sometimes it's about, okay, the care manager will assist or really advise people to the importance of communicating. So finding out, who's working in the hospital on discharge planning. Kate mentioned before, although Medicare provides and indicates that discharge planning is part of the role in hospitals, it varies from hospital to hospital on what that looks like. And whether someone is assigned or whether the patient or their family has to seek help. So it's not always automatic. So what we recommend is, as soon as possible, to be saying, I want to know who's the person that's going to help with discharge planning from the hospital side. I'd like you to ask the doctor or the nurse to refer me so that you get on that list to be seen by a discharge planner right as early as possible. And then to communicate, what's the situation at home. If someone doesn't, lives alone, that's important to know if there's going to be pieces of the discharge plan that would require support. So kind of communicating early on what's happening. But sometimes our care managers get involved literally and they're saying, oh, they want to discharge them today, tomorrow. And my parent lives alone, and they're going to send out some care, but it's not going to be there all the time. There's nobody at the house. And I'm the child and I live out of state, and they're on the phone saying, what do I do? And so, again, back to the communication, sometimes the first piece is to use language that the hospitals understand. Like, it needs to be a safe discharge. And to communicate, this person is alone, and we don't want this person to be returning back to the ER within 24 hours or very soon, because if they are going to be discharged now, there's nobody in place at home. And so it's just kind of getting everybody to slow down for a minute. And also clarifying right from the start, are they admitted fully to the hospital? That's another question. As soon as someone gets to the hospital, I think there's been more and more out there about the issue of observation beds. And so, when someone's at the hospital now, you needing to clarify, have they been admitted fully? or are they in the observation status? And it makes a difference because it impacts what you're eligible for services. And so, that's another question we ask right off the bat. Sometimes you can be in a bed, in a room, on a floor, and the person next to you in a shared hospital room is admitted, and you are on observation status, and you don't know. That also impacts if you're going to have a discharge planner. When I said before, to ask for someone right from the start when you get in the hospital. If you're in an observation bed, the idea is they're okay, they just need a little more time, and you don't necessarily have the full complex of services that may be available to you if you're really in a hospital, admitted fully. So the other thing a care manager will do is to really get a full story of, okay, well, how is this person, sometimes we have someone who might be very, we had a situation of a referral of a 95-year-old gentleman who fell, had been independent, he and his spouse, and very active, and unexpectedly had a fall and went into the hospital. And that, when you're having someone who's very independent, to then make plans for a lot of care afterwards can make a big difference. Now, in many cases, we're going to say, has a physical therapist evaluated you inpatient? Again, let's get that referral from the hospital, because that it can give you more time, and it gives you more information to say, I need a little more assistance, my parent, my spouse, after the physical therapist gets their assessment, you have another professional that's able to articulate, is this person have enough supports in that home, or how much do they need? And a care manager works as part of the team. We work with the hospital discharge planner, we work with the physical therapist, and trying to say, okay, let's see what's needed. And let's see what else, what referrals are needed. So if the hospital discharge planner is making a referral for home care, right? Well, that's overwhelming sometimes. You're wondering, well, what does that mean? What's covered for home care? Is it going to be paid for? How often are they coming out? And, Medicare, will cover, if you meet the criteria for skilled home care, a nurse to come out, or if you need a physical therapist to follow up with you, a physical therapist to come out. And then they say they cover some intermittent home health aid assistance. And that's the piece that a lot of people need. That's help with, for a while, if you need help with managing meals, or someone to help with bathing, or with laundry, and kind of those practical pieces. But Medicare doesn't cover a lot of that. It's a very small amount. And there's not a schedule, so part of the care manager's role is education. So it's really to go in and to say, okay, you've been told that by the hospital that they're ordering home care. But let's talk about what that means. What's that going to look like? That you're not going to know necessarily that they're not coming at a certain time. They're going to come out the kind of the next day. So then the care manager may be talking about, okay, do we need to supplement that? What else? Are you going to need to hire someone? Again, what's the costs? What agencies, and the different options of going with an agency where everybody's on staff versus a registry versus a private individual. There's lots of, essentially there's a lot of choices out there, and it can be very overwhelming.
Could I just
please
interrupt for a second? There's an emergency packet as part of the information that's being given out today, and I know you've seen these questions before, but it really is a help if you've got the answers written down. Another website or resource, if you're asked to, if you're going to be discharged, Monica's talking about being discharged home. If you're going to be discharged to a rehab facility, you may be asked, which rehab facility do you want to go to? So how in the world are you supposed to know? And if you have a spouse or someone who is going to be your health care, your advocate, or is going to be able to answer the questions or do research for you, this is really handy. If you're on your own, this is, again, an area where you're really vulnerable. So it may help to kind of take a look at these websites in advance. The one I'm thinking of is through, it's through Medicare, cms.gov, and we'll put this up on the, yeah, it's up there. And it's Nursing Home Compare. And they have a rating system, it's called a 5-star quality rating system for nursing homes, rehab centers. And of course you would want to be in the very best center that you can, in your area if possible. There's a term that's kind of thrown around called medically necessary. Can you give it a definition for that, or do you know how that applies? What is medically necessary?
Well, I think that can mean a lot of things in a lot of different ways, because when we look at medically necessary, there's usually some type of criteria or standards that we look at. And for instance, if you need home health care, there has to be some type of skilled need in order for a nurse to come out. So what do we mean by a skilled need? So for example, if someone needs to, let's say they need meals prepared. Really, when we look at private payers, and even on the Medicare side, meal preparation is really not a skilled need in their broad spectrum, correct? And, right, but as far as like if you need an IV or if you have wound care, so they're looking at it in that perspective of that's medically necessary. We need to send a skilled nurse out to the home to look at the dressing, assess the wound care. So that's what we mean by medically necessary. When you hear that term, because I'm sure you've heard that, and so you're kind of thinking, well, medically necessary, I'm sick, I need somebody to come out here. And when you're talking to your insurance, Medicare, whomever it may be, they're saying, well, this is the criteria in order for it to be medically necessary for someone to pay for it. And so that's what we were referring to before. You know, Monica was referring to, so that 1 hour a day that a skilled nurse might come out may not be enough. And what do I need to do to get someone else to come out and help me? Is it that I need to, go into my other, my secondary insurance, or do I need to set up private pay, or do I need to have family come? What resources do we have to help us get through this event or this life change?
Yeah, so much will depend on the network of family or friends that you have, also on the reason that you have to be hospitalized. And it's good to have, if it's an emergency hospitalization, you may not have time. Of course, you're not going to have time to plan. If it's elective surgery and you've got some time to figure out what kinds of services you're going to need once you're going to be discharged, you may be able to get something in place, but so much is going to depend upon your understanding of the illness, of your primary caregiver, whether or not your primary caregiver will be able to provide the care that you need at home. What happens if you feel that it's too early for a discharge, or that you really and truly don't have anybody at home who's going to be able to take care of you? Any thoughts on that?
So if you think nobody is at home to help you take care of the person that's being discharged or for yourself, as we mentioned, one of the things is to communicate that with the hospital, and to very clearly that, when they're looking at what's needed for someone to go home safely, that support network is not in place. So if you have someone that is not going to be able to be managing their own medications, you know, or getting in and out of even, let's say, the bathroom independently when they're first at home, you know, after you've been in the hospital. The reality is when you've been in a bed, if you've been in the hospital for 3 or 4 or 5 days even, and if you haven't been moving around much, the impact on someone's strength can be really shocking sometimes. And so that's really important to, again, to have that, an assessment of how things are going before being released. But sometimes there's a realization that one can't go home right away. And so, you know, maybe asking about, well, is a subacute stay something that's needed? So rather than going from hospital to home, going from hospital to a skilled nursing or subacute facility for some time to continue to get stronger, to get physical therapy, to have meals and good nutrition and medications managed as a bridge before home. And Medicare does cover for if you meet that, you know, we've heard about what's medically necessary before. So if you meet the criteria for needing skilled care, which can include the need for physical therapy, then Medicare will cover for you to go into a subacute until 100% for the first 20 days. And if you're continuing to need that skilled care, then after that, on the 21st day, often that's when maybe if you have a secondary, like a Blue Cross or another policy, the Aetna, will cover that secondary. But knowing what your policy covers, so you know, do you have 30 days at 100% or is it 100 days at 100%? That varies from different policies, and understanding what your coverage is. And that's an important, you know, that can be an important piece. And then knowing what your options are. Again, different parts of the country have different options for facilities. Sometimes it can be also overwhelming though, because you know, sometimes you're given a list, so it's great to have the sites, and sometimes the hospital will say, okay, here, when we've had a situation where we, you know, had a spouse, or maybe it was a sister in this case, say, okay, the hospital said, you know, my brother should go to a subacute, and can you help me? They gave me this list, and then she shows us the list, and there's like 25 places on the list, okay? And said, I have to choose, how do I know? Well, that's really hard. That's overwhelming, isn't it? So that's a place to get help. And yeah, I mean, there are certain things that you're going to be narrowing it down, like making sure, you know, that, well, looking at geography, you know, looking at is there special needs that your loved one has. So for example, you know, you've got lots of subacutes, but do they handle special things like if a person has a trach? Well, that's going to narrow down your choices a lot. Or, you know, if there's another particular, you know, issue that's involved, maybe the person has high anxiety, and you really need to look for something that has a smaller setting that offers a subacute, you know, and so, you know, those types of things is an area that a care manager can also help with, in addition to your resources for care management, whether it's through Aetna or at the hospital. And that's where you have to sometimes ask for help and say, I really need help. Also cost, making sure, you know, what are the costs? You know, also knowing if the Medicare covers for a subacute, it can be, you know, usually a semi-private, 2 people in the same room. But there are some settings where you might have your own room but a shared bathroom. Well, if it's really important to you to have your own room, or you know your loved one.
You have the rehab people coming in, you have your doctors, you have your anesthesiologists. So at some point, you're going to get either a social worker or a care manager. It depends on what the hospital has. So at that point, you may have someone ask you and say, do you have someone that can take care of you at home, or do you have someone at home? Because of course we talked about safety a little bit, and they want to make sure that you're going to be safe when you go home. So I think that's when people come in and they start asking you those questions. But a lot of times that means so many different things, because maybe your caregiver has to go to work. So what happens when they have to go back to work? Maybe they can take off a couple days, but then we need to figure out what is it that you need when you go home. Do you need someone with you 8 hours a day? Or can we send in a nurse, do kind of that piece of and a lot of times we'll send the home health care nurse out, and then they'll do the teaching to the caregiver, and then the caregiver is expected to help with some of that, with either changing the dressing or making sure that you're taking your meds. So it's almost, because it's not ongoing forever per se. So the purpose of home care is to send someone there, do a lot of the teaching that we talked about, provide that support. There is support for caregivers, because that could be difficult on the person taking care of someone that has those needs. So a lot of times, that's a lot of stress on someone when they know that they have to take care of someone, and how much do they really need to do, and what is it that they have to do. So I think in the beginning, it's just making sure that we're upfront and we know we're clear with the caregiver of what's really expected once this person goes home, once the patient goes home, and what we have to do. So, because a lot of times people come home and it's like, oh, I didn't know I had to do this. I said I would be the caregiver, but I thought I would just have to sit there and watch the person or make sure that they're eating and drinking. But then they come home and they've just had surgery. You have a wound, or you have something, or like the trach, or things like that are a little more expensive. So it could be overwhelming. But then I think also knowing that where the resources are, who they need to talk to, who they can call. I think that's the big piece of it. People knowing that they have the support.
One recommendation is to have that telephone number so that you know 24/7 that you can call somebody if there's an emergency or if you have questions about care. Another area where things can get a bit dicey is moving from a hospital or the rehab center to home, and medication. When you're in the hospital, and just show up with your prescription drugs. When you go home, who's supposed to be you're supposed to leave the hospital with the prescriptions. Who's going to fill the prescriptions? Who's going to make sure that you've gotten the right prescriptions? And so there are quite a few areas where you really have to be on the ball. Somebody has to, either you have to do it, or you have to have somebody who can be paying attention for you on your behalf. If you two don't, would you mind if we take questions at this point?
I wanted to just make one comment on that piece of the, certainly right, with the medications, it's true, it can be very challenging because not only are you going home with potentially new prescriptions, but we've had the situations a lot where people are leaving with prescriptions in their hand. Depending on the time that they're discharged, their pharmacy may or may not be open. And all of a sudden, they're thinking, I've got to go, 12 hours, or maybe the pharmacy doesn't have the medication. We've been told that too. Well, we're going to order it, we're going to get it on Wednesday. What? What is that? So, there are pieces that just involve, it seems pretty straightforward, but all of a sudden, each piece that you're talking about, whether it's medication, transportation, getting back and forth to the doctor, getting the support, each piece can actually mean a lot more, and it's sometimes a need for help. There are more home care agencies in the area also that are offering like a flat fee package. And I don't know if Aetna has a package to start with, but if your insurance doesn't, they have a flat fee package for hospital to home, where they will include someone coming to the hospital to get you and bring you home, an aide, a caregiver, and go to the pharmacy and get your medications. Go to the grocery store and get some meals. Make sure you have your clean linens and get a shower. And so there's that first 2 days home, they come in and out, and it's a flat amount, and it's kind of like a package to get you a start. And sometimes that's all you need, but that can be the really big important piece, and that's very value added. And so kind of knowing what's out there and in what area, so that when you go in the hospital, okay, well, I know I can call on this agency for this flat. I know what it's going to cost. I know the package, and we can go from there.
Well, I want to hear more about that. I didn't know about that. like to open it up to you. If you have questions or comments, nightmare stories you'd like to tell us about.
It's my understanding that whether you're admitted to a hospital or just taken in on observation status, that impacts whether your insurance company pays for your stay in the hospital. How can you insist that they admit you? Can you say to the hospital, hey, if I'm going to be here, you have to formally admit me so my insurance pays for it?
Paula, are you?
I think Paula will help us with that.
Okay, so here's the deal. If you go into the emergency room and they put you under observation care, you may or may not know it, so it's very important that you do know it. No, you cannot insist that they move you into inpatient. You can beg, you can plead, it depends, but they probably will keep you as observation care. I would go into why, it's part of the CMS rules, but it doesn't matter. If you are in inpatient and you have Medicare A pays, and then your FEHB plan pays the balance, the deductibles and all that stuff. If you do not have Medicare Part B, how many of you do not have Medicare Part B in this room? Okay, so if you do not have Medicare Part B, somebody may come into your room and say, you're under observation care, you don't have Medicare Part B, this is not covered. Well, when they pick you up from the floor and put you back in bed, you will know that you have the FEHB, and the FEHB will pay under the outpatient medical part. Now that sounds really great, right? Except that is mostly subject to a deductible and a co-insurance, a copay, but you are covered at least. I mean, if outpatient is 90%, then your health plan will pay 90%, so you are covered. But it's a dicey road. You can't really convince the hospital, and you can't get them to change the code. Once that bill goes into your health plan, that is exactly how your health plan, by law, is required to pay it. So if you can call the health plan and you can say, I really was sick, I really was inpatient, they even put me on an IV, and there is absolutely nothing in your health plan, because it's illegal to change the code. But you're all feds, you all have one of the FEHB plans, and you're okay. Private sector, not so much.
Is there a length of time that you can be in the hospital under observation?
There is supposed to be, it can be anywhere from 24 to 48 hours, but it can also be 3-4 days. And you really do think you're inpatient, but you're not. It's coded as observation care. So, and many plans, I changed the language in the Foreign Service Benefit Plan brochure, what, about 4 years ago did we do that, Pam? Just to make sure that people understood the difference, and there's a really big difference.
What about being retroactive? I'm just curious. If you're admitted as observation, and after one day they decide you really do have a cancer or a blockage or something, is it then retroactive?
So
that you go, that first day of observation becomes admission, or does it just start?
So the question is, if they admit you under observation care and they find that it is more serious and it is actually supposed to be inpatient care, the hospital could, before they submit the bill, they could change that. Wouldn't count on it though.
And to say that's important because we talked about subacute stays before. You need 3 overnights in the hospital as an inpatient to qualify for Medicare to then pay for you in the subacute setting. So if your first 24 hours is under observation and then they decide you need to be admitted and you're there for another 2 nights and then you go and you think, well, I've been here 3 nights. Well, the first one, if it didn't count and you go to that subacute, you may find that Medicare denies that coverage. And so that's a thing to really check on the front end to say, I need to be inpatient for 3 overnights in the hospital in order for Medicare to cover me at the subacute.
And a subacute is,
It could be a skilled nursing facility that offers a rehab subacute. There are a couple of hospital-based in this area, like Sibley has a subacute wing, but it's, so the setting can vary, but often it's a nursing facility part of it, like a wing or a section that's separate for, yeah, short term.
Yeah, I just was gonna add, it's almost like a transition floor. So when you get admitted, you know, you're more of the acute stage, so then many facilities, the subacute means that it could be either a rehab or like a skilled nursing piece to give you some time to either they offer physical therapy, occupational therapy to get you stronger to go home.
it's no longer inpatient hospital.
It's still inpatient, so because you're in, it's still inpatient because you're in the hospital.
Well,
But it also depends
or
on how the.
you might be discharged, if you're at a facility, you'd be at a, it depends. But you're not in the hospital anymore at that point, no,
Right.
you've been discharged from the hospital.
Right,
It may not count on towards the 3 days,
correct.
the 3 days.
No, because it's a
No.
different level of care.
Happened to me.
So we have another question over here.
Do the medical plans now cover single rooms? 6 years ago, I was seriously ill in the hospital, and the doctor put me in a single room for which I had to pay a substantial amount so that my family could visit me any time of day or night. But now I know that Sibley Hospital has exclusively single rooms. Would they be covered?
Sure, yeah. I think many of the hospitals are going to single rooms automatically, but that would be covered.
Yes, but I don't think there's an extra charge for that at that point. I mean, I'm not seeing that come through. I don't know how many years ago that was, but usually there's not, it's based on availability at my point, and Kim is one of the supervisors that works on my utilization management area, and usually it goes based on if they have the availability to do that and what the space is. But I'm not aware of them charging extra for that.
Thanks for your presentation. Monica, I think you were talking about these flat fee packages.
Yeah.
It would be tremendously helpful. Where can we get information about these, who offers these in advance?
Sure. So I certainly can either give Kate you some to give out following the presentation, or my email is also listed. I mean, certainly we know of the local ones, but there are these are being offered more and more nationally in different locations. So I have to check to give you the ones in the other areas, but certainly the local packages. So I'm going to say $100, but a lot of them do it for $100, and they give you a certain number of hours and a certain number. It's really more task oriented than time oriented. It's a package, or 200. Usually is $100 is what they have as a starting package, but there may be other options.
Thank you very much. Let me, if this isn't an appropriate question for you, y'all let me know. But I want to give you 2 healthcare situations. Person A is diagnosed with breast cancer at the age of 70. And person B is diagnosed with prostate cancer of some sort. And they're going to go into a hospital. So for each of these people, and they're single, what would you suggest how would you suggest they proceed in understanding how the coverage will work? I mean, can they call your office? I'm looking for that piece that says, all right, I've got this diagnosis. And then who do I call from the insurance perspective to understand how I proceed? Male or female? That's why I'm giving you prostate cancer versus breast cancer.
Thank you.
Yeah, so your first step of what you can do is, obviously you can call your benefits area, to get some basic information, but you can request a care manager as well, and they would help you walk through that process in regards to, and obviously we can't as far as like the cost and everything like that, because everyone's different and the treatment plan would be different. But your first step would be, you could call your insurance company and say, I need a care manager to help me through this. I've just been diagnosed. This is a new diagnosis for me. Can you please help me walk through this? And understanding who is it that I need to contact? What are the resources available to me? And that would be your first step.
And that number I know for Foreign Service Benefit Plan, it's the number you can call for care management is in the plan description each year. So you wouldn't have to wait, or be referred by your doctor. You can do it.
Right. You can do your own self-referral as soon as you find out.
In your experience, which is vast, obviously, would you care to put yourself in the hypothetical situation that it is your mother or your father who has to go into a DC hospital and he or she will need care afterwards? Which hospital would you recommend? And we will not publish it in the Washington Post.
So much depends upon the doctor.
Yeah.
The doctor who says that you have to go into the hospital. So, most doctors are associated with certain hospitals.
But you can make that selection ahead of time. If you have a certain illness, and there are 3 hospitals that cover it, you choose the hospital.
Right.
Right. Going to take care of you after.
Right, so I won't answer this as a nurse. I'll answer this as pretty much like you're saying, if my mother was going to go into the hospital. So if my mom goes into the hospital, and recently we've had to do some, find a specialist for her for a certain diagnosis, is if my doctor gives me 3 names of facilities or 3 doctors, I'm going to go to Google, and I'm going to go and pretty much research. And I like to look at the reviews, because as soon as you plug in that doctor's name or that facility's name, you're going to see people put in reviews of, this doctor had great bedside manner, or, I didn't have a great experience with this doctor. And so I usually go and do my research on the internet, because people post their opinions, and I think that's important when you're looking at that. So and then you also see that star rating, there's star ratings. That's pretty much what I did.
CMS.gov for nursing homes, subacute facilities, rehab centers, does they really do spell out what they're looking at when they do ratings, and how often they check places, and what the stars mean. So they do health inspections, staffing, and quality measures. Quality measure rating has information on 16 different physical and clinical measures for nursing home residents. Of course, nothing beats actually going to a place and checking it out. The other thing is that there could be a place that has a high rating, but it's really inconvenient for you as a caregiver or relative to get to. And really nothing tops having somebody come to visit a patient frequently, just to see what's going on, get to know the staff, and make sure they know that they're being watched.
I would second the idea of, if it's possible to go, of course, that's an ideal, but even whether it's, if you have the option again of a care manager, through, whether it's through Aetna or, another policy or private care manager, but part of that is to, part of their role can be to help you to choose. Okay, so here out of these 3, what should I be looking for? And for us, for our team, in terms of doing more local care management, we're out and we're in the field, we're on site, so we're in and out of facilities all the time, and and so there's also the opportunity to say, okay, so how can, what are people's experience? And there are times, based on a person's diagnosis or based on their other medical issues, like I mentioned, like if they have, high anxiety, you may be looking for a setting that also is a smaller, where they're going to have eyes on them more than maybe another person where they're going to want, more autonomy. But a care manager also, aging. There's a national association which is called the Aging Life Care Association. In addition to what's available under your insurance and other groups, if you feel like, I really need someone who can go out in person, who can be by my side as an advocate and really, flesh out a lot of details, be the person going on to the doctor's visit to ask questions, or to be maybe my parents in another state and I need boots on the ground there to really help me. There's a national organization, Aging Life Care Association, and it gives you people that have met the criteria, and you can look by state, and then you can see what's available to contract with a care manager to go out and do assessment, to make recommendations, and it can include helping to choose which facility, whether it's one over the other. So that's a resource as well.
A quick question, and it came up when my family employed a care manager, a private care manager, for my grandmother. So I have to ask, I have a mother who lives in a different state. If I were to hire someone, does that person work for me, or are they looking out for my mom's interests, even if they differ from what I want for her?
That's a really good question. Yes, it is. I can't answer for all care management groups. So I'll give you the answer from our perspective. So if you were hiring us to work with your mom, and you lived in another state, so we're very clear to say, the person who is our client is our client. Now, if a child is asking a care manager to help them with, let's say, a particular role, and let's say there's disagreement about what's needed, okay? Child thinks mom shouldn't be at home anymore. I'll take the dramatic one. Parent says, I'm staying at home. I'm not going anywhere. So sometimes the care manager actually, they're taking on that role to say, we're doing our own assessment and we're going to make our own recommendations. And that's the value of having a care manager. And we'll tell the child, look, I can't tell you, we're going to tell you what you want to hear. We might come back and say, you know what, with some supports, or maybe your mom or dad are doing okay right now. Here's our concerns. Here are the things we might want to address, or here's when you look for a red flag. But we might be saying, it's important to support your parent in doing this, which is not what you had in mind. Or other times, we may be saying, yes, here's some recommendations for your plan. But really, so it's about what's in their best interest, and it takes that into, you're both the client in a way, and that's what you have to have that objective. You have to have an objective professional role, or it's not going to be very valuable, essentially.
Okay, we have a few minutes left. We have one question here and time for one more.
Thank you. Just a quick follow-up on that last point. I had exactly that experience with my mother in another state. It took me forever to find a geriatric care manager. Got her over. She said, she gave the wrong answer. She said, oh no, she's fine by herself. Suggestion for everybody, what we ended up doing is I got a couple of names from her, people in the area who just kind of private, on their own would kind of help people out. I checked them out. I introduced one of them to my mother as a friend, therapeutic line it's called. Set up a situation for her to go back on a regular basis and kind of, got somebody boots on the ground there during that transition period until the transitioning event. But my question actually was a follow-up to the follow-up on the a flat fee package when you're in the hospital and then getting resettled at home. Is there a term of art? What do we call that if we're checking out the availability for
I'm trying to, different groups usually have called it something. So whether it's, a transition home, and now, of course, I'm not going to be able to remember the names, and it's that recall, and I'm going to start worrying about from the presentation, and the first steps of recalling the name, but, so there isn't like a set name, it's really more like a marketing thing of the way that they would term it, and, but I can definitely give information out on, as I said, several of the local offerings, and it's more and more being offered because it's being used. In some hospitals, once in a while, the hospital will even look at covering it because if it's going to, get that person home safely, it's very value added. It's just a critical piece, and you're not committing to a long-term arrangement or a lot of things. So I'll definitely get that information out.
So the website is going to have all of the resources.
Yeah.
The Senior Living Foundation website will have the information on all of these wonderful topics, as well as the resources up within the next week or so. All right, so we'll get that.
Does your company offer that package?
So we're not a home care agency, so we don't offer the package, but we work with a lot of home care agencies, and so you could call my number, and one of the other things we do is we give information and assistance, which is just a service to the community, and I would give you those names and tell you, okay, here's the ones we worked with, here are the things. So we can give you that local information, but then I can also refer you to other sources on other parts of the country.
I've recently had an experience with physical therapy, both in-house and at home. And I must say, I was much impressed with physical therapy at home because in facilities, you get your hour or whatever of physical therapy, and then you are in bed. And at home, you are more apt to get up and do that.
Great. And I think that's a good point, is to say, sometimes people are going in and the plan, we had a situation where we had someone we were working with where they just automatically wanted to send the person to subacute. And sometimes going home is better for a whole bunch of reasons. And so sometimes you're actually advocating for, wait a minute, we want to talk about going home and why it's going to work. So I think that's an important point to say. It's not cookie cutter. You really need to see what's going to be right for you.
Right.
Is there someone you could recommend we could contact to answer a question I've always had? If we have the Foreign Service Benefit Plan, do we need Medicare Part B?
I'm going to jump in here in place of Paula.
Thank you.
Welcome to the chat. We've got some information on that actually on the table and are happy to talk to you. I've got my cards. I'm happy to have an individual conversation, as is Paula and some of our colleagues. It is an individual decision. We've got some guidance and so forth, but it really is an individual decision. And perks and challenges that come along with it for each person. So we're happy to talk about that during the next break, which is after our next panel. I think this is the perfect time to wrap up.
Thank you.